Welcome to this Myeloma University module titled Transitions of Care. My name is Beth Faiman, and I am a nurse practitioner at the Cleveland Clinic in Cleveland, Ohio. In this brief discussion, we will review important concepts in the transitions of care of patients with multiple myeloma. Now let's begin. The healthcare landscape continuously evolves, bringing new challenges and opportunities in specialized, complex treatments and therapies, and myeloma is no exception. Recent meetings at the International Myeloma Society and the American Society of Hematology and others have shared breakthroughs in the treatment of multiple myeloma. In this dynamic environment, the concept of transitions of care has emerged as a crucial aspect of patient management throughout the myeloma disease trajectory. Transitions of care refer to the movement of patients between healthcare practitioners and settings as their condition and care needs change. Transitions of care can occur at any time during the myeloma treatment phase. Effective and efficient care transition is so important for many reasons. First, patients do not always reside in close proximity to a myeloma specialty treatment center, but may want to partner with a referral center because of the treatments are good and they want to then receive some locally. Or they might want to travel in the summer or winter months for a well-deserved vacation or for other various reasons. Or the patient might choose to participate in a clinical trial or receive bispecific antibody or CAR T-cell therapy and need more specialized supportive care to manage symptoms or the disease. I refer to these as critical periods where there is a need for more care coordination and discussion. Patients with myeloma often have different critical periods where there will be a need for more care coordination between the community practice, hospital-based referral center, and the patient. Common examples of critical periods include the need for more information and communication sharing at the time of diagnosis, at the time of relapse, or when they do enroll in a clinical trial, or as they embark on immunotherapy treatments. The increasing prevalence and advanced treatments such as CAR T-cell therapy or bispecific antibody highlights the need for these relapsed and refractory myeloma patients to have these care transition discussions. For patients to successfully receive these novel therapies, effective and efficient communication between all parties, the referral center, community practice, and patient, is key. First and foremost, the transition of care requires collaboration and buy-in from all patient healthcare team members as well as their patients and caregivers. To accomplish a successful transition of care, numerous barriers must be overcome depending on the practice setting, the geographic location, such as fragmented care transition workflows, lack of engagement with community providers, lack of personalization to the patient, lack of engagement to the patient, poor communication, or lack of attention to caregiver and social needs. These barriers may be reduced by discussing them with the local oncology team directly, as well as providing a written handoff, ensuring the communication is of high quality and including the patient and caregiver in the transition. Partnership between academic and community health team members and high-quality communication, patient and caregiver engagement, and information of shared decision-making, along with ongoing evaluation and adaptation of transitional care strategies, are required for these care transitions. I think of transition of care in terms of phases. Now, as mentioned before, this can be important at any phase, from diagnosis and upfront treatment to stem cell transplantation to clinical trials or advanced therapies. In fact, a common scenario is when a nurse might be communicating with a community hospital in another geographic area as a patient plans to leave for several months at a time and continue with their ongoing maintenance therapy or supportive care or disease monitoring. So what does this handoff look like, and how is this done? We will discuss this in a moment, but for the sake of discussion, let's think of transitions in terms of CAR T-cell therapy or the bispecific antibody therapy in phases of patient care. The four key phases of CAR T-cell harvesting and infusion are the pre-cellular therapy phase, which includes patient referral, screening, staging, and fitness, as well as financial and disease assessment. The second is the immune effector cell collection by white blood cell apheresis or leukapheresis. 3, the lymphodepletion, infusion of CAR T cells and supportive care. And 4, the treatment and follow-up. So in this scenario, the first handoff occurs when a community center refers the patient to a referral center to receive either the bispecific antibody or CAR T cell therapy. Now, regardless of whether or not the patient receives the bispecific or CAR T-cell therapy, this is where effective communication is critical. When patients are from the community and seen and evaluated by this referral center, it is important for the patient and the care team know how the centers will be willing to communicate and with whom. Finding a point person is critical. Some centers have an electronic medical record and they choose to see updates through their EMR, and others want communication by a facsimile. Currently, most small and large hospital and medical centers will have a dedicated nurse coordinators or a care team with one person who serves as the point of contact. With the importance of timing and care coordination, a quick phone call and documentation of the telephone encounter is really important between the patient and each care center. Moreover, once a strong relationship is established between clinicians at academic and community center programs, communication and referrals are often streamlined and easier for others. Patients will be handed off to the care centers for the step-up doses of bispecific antibodies or CAR T-cell therapies, but must be educated on the post-acute adverse effects of the bispecific antibody and CAR T-cell treatment. These can include a number of things such as cytopenias, infection risk, B-cell aplasia and hypogammaglobulinemia, secondary primary malignancies, neurologic toxicities, fatigue, and even infertility. Ongoing disease monitoring on a regular basis is required to assess for remission and relapse and to ensure patients maintain adequate organ function. It is also recommended that patients who receive bispecific antibody or CAR T-cell therapies remain in contact with the referral center just in case another line of therapy or a clinical trial is necessary. It's important to consider what are the patient and caregiver expectations to be addressed in the documentation. I provide the referring institution with a handoff, a list of recommended antibiotic and antiviral prophylaxis drugs, the need for IVIG, and the necessary disease monitoring information if they receive either the bispecific antibodies or CAR T-cell or any therapy. And I also ensure similar communication for patients traveling to another city during the summer or winter months. In addition, I encourage patients to stay connected with our center to keep lines of communication open even after this therapy is administered, but also to be clear who is monitoring the disease, who is making sure they're still in remission, and who's administering any ongoing treatment. Please see the survivorship module, which highlights the importance of a survivorship care plan, a written health record which can be shared with patients and providers. Given the novel mechanisms of action, unique side effect profiles of these therapeutic modalities, and potential life-threatening toxicities, the nursing, patient, and provider communication and education and collaboration are all critical to effectively coordinate, provide safe care, and ameliorate potential poor outcomes. Providing a clear handout, knowing who to call, when to call, and who is monitoring the disease are all critical points that can lead to a successful transition of care. The Nurse Leadership Board has also written a paper on transitions of care that you may find helpful. You may also see these other resources on this topic. Thank you so much for joining us today to share in this important discussion. For more information, please see these additional resources on the myeloma.org website and watch for additional segments in this series. Thank you.